So welcome to the 52nd Pain Journal Club, and today we're going to discuss a very important topic, which will be radiofrequency ablation in Coccydynia. And today we have Dr. Maitri Shah who will speak on this topic, and Dr. Jeshnu Tople who will moderate the discussion. So I'll just make it full screen. Okay, so I hope you all can see the presentation now. Okay, so let's begin. Mumbai Pain School has been evolved because pain medicine world over has got diverse issues and variable standards, different learning requirements, and different offerings. And money and time are limiting factors which prevent the physicians from learning, and there's a lot of issues because of this reason. However, our endeavor is to bridge the gap between education and practice. And as a result, Pain School is there, the Mumbai Pain School, which is an initiative of the Panisha Spine Wellness and Pain Relief Center. We are using online media like Facebook, Instagram, Twitter to promote the pain education across the world. With humble beginnings, we started with online learning, on-demand videos, and now we have got both free and paid content. We've got hands-on workshops, 2 of them already conducted, and the third one is due in March. We are fortunate to have expert faculty from all over the world. It is said that the best teachers, they teach from the heart and not from the book. So Journal Club is nothing, it's just a club with where we critically evaluate the recent academic literature, which is based on a defined subject, and attendee participation is encouraged. So guys, please feel free to ask questions, give your comments and suggestions. If you have anything, just type in the chat box and we'll take it up. It is tough to be regular. So Journal Club is a regular educational activity, and I understand that it is very tough to be regular, but those who can be regular will reap the benefits because this is a super specialty and you need to know much more than what you think. Even Harrison had his own journal club twice a month, where he used to critically evaluate the academic literature. So time is key, so we will stick to the timelines. Healthy skepticism or praise is most welcome and appreciated. This is a bit about me, and now I will introduce Dr. Maitri. Dr. Maitri, you can just put on your slide. I will just stop my screen share. Just hold on.
So is it seen?
Just a minute. Yeah, I can see your slide. So Dr. Maitri Shah is DA MBBS. She is fellow in pain medicine at the Department of Pain Medicine, Patil University School of Medicine, Navi, Mumbai. So I will introduce Dr. Jeshnu after your talk is over, when he'll speak. So over to you, Dr. Maitri. You can start now.
Yeah. Good evening, everybody. Sir, am I audible?
Yes.
So my today's topic is improvement in pain following ganglion impar block and radiofrequency ablation in Coccydynia patients. It's a systemic review taken from Rare Plus Ortho, Sao Paulo, 2021 October, done by Ranjit Chaudhary et al., performed at Department of Orthopedics, AIM, Raipur, Chhattisgarh, India, and Department of Orthopedics, AIMS, Jodhpur, Rajasthan, India. So the introduction. Quickly, I'll just go through what it is. Already, sir has explained all these things in his talks. So coccydynia relates to the pain and tenderness around the sacrococcygeal region, worsens with prolonged sitting on hard, narrow, uncomfortable surfaces rising from the seated position. It is multifactorial in origin, idiopathic, traumatic, infection, and tumors of coccyx, obesity. Incidence is found at 5 times higher in women than in men. Cases fail to resolve with conservative treatment such as NSAID, physical therapy, coccygeal cushions, require invasive interventions. Non-surgical intervention treatment modalities such as caudal epidural steroid injection, ganglion impar blocks, radiofrequency ablation of ganglion impar, and chemical neurolysis of the ganglion impar. The surgical intervention consists of coccydyectomy, but it is rarely required and used only as a last resource. So, introduction about the ganglion impar. And ganglion impar is a solitary retroperitoneal ganglion representing fused termination of the bilateral paravertebral sympathetic chains located at the level of coccyx, which is shown here. And this is the ganglion impar. It is a sensory relay station of the nociceptive stimulus from the pelvic and the peroneal zone. Ganglion impar blocks are employed for the management of perineal cancer pain from rectum, vulva, prostate, as well as chronic non-cancer related pain such as coccydynia and chronic pelvic pain syndrome. Ganglion impar block can be done utilizing various modalities. So the objective of this study is to know the improvement in VAS following the ganglion impar block in coccydynia patients, to study the improvement of VAS following the RFA in the ganglion impar, and to study the difference in improvement in VAS following the ganglion impar block and radio frequency of the ganglion impar. Methods. A comprehensive and a structured search was conducted using Cochrane, Medline, EMBAS, and CDSR databases. The assessment of methodology, strength, and validity of included studies was done by utilizing a framework, the NIH, the National Institute of Health, to ensure reproducibility of the process for before and after, pre and post studies, like the pre and post procedure studies. VAS and NRS scores were used for primarily outcome assessment. So this table tells us that there were a total of all the studies went through the screening process according to the inclusion criteria by the various authors. And finally, there were 7 studies which were taken into consideration, and a total of 189 patients were studied. So the inclusion criteria would be study with the age group beyond 18 years, presence of symptoms for at least 3 months, participants failed to show pain improvement after conservative treatment, followed for at least of 6 months. Exclusion criteria would be participants who underwent any other kind of local injections in coccyx region, studies describing surgical interventions involving the lumbar spine, pelvis, including patients with cancer or cysts. Any case reports, conference presentations, and unpublished trials were excluded. This is a table showing the data extraction on the basis of demography and epidemiology of the ganglion impar. So that is year in which the studies was performed by the authors, the number of patients included, age, BMI, whether the coccydynia was because of the trauma, the approach used, the scoring system used, the material used, the baseline score, that is just immediately baseline is before the procedure, then the short term was immediately after the procedure, intermediate relief was 3 to 4 weeks, and long term would be more than 3 months. If there were no improvements, if at all any complications, such as they faced only 3 complications in total. 2 had a vasovagal reaction, increase in pain, and 1 had bradycardia and hypotension. Similarly, this is a table for radiofrequency ablation done in the patient. There were 4 studies done at different years with the same parameters used. Now, results and discussion. A total of 189 patients were studied, out of which 104 patients were in the ganglion impar block group and 85 were in the radiofrequency ablation group. The mean age ranged between 42.64 to 42.9 years in ganglion impar block and 42.52 to 51 in the radiofrequency group. The weighted BMI was 27.24 kg per meter square, and the mean BMI ranged from 24.73 to 29.49 in the ganglion impar block, and similarly the range was 26.46 to 27.98 in the radiofrequency group. Also, the history of trauma of the coccygeal region was reported in 64.7 patients in GIB, that is the ganglion impar block done, and 60.7 patients in RFA group. The primary outcome, as discussed, was mainly assessed by the VAS score and the NRS score. So this is the table for primary outcome of two modalities. That is baseline, the VAS was 7.83. Short-term relief mein there was 3.11 score and 4.25 at radio frequency ablation, and VAS intermediately 3 months at ganglion implant was 355. Radio frequency we did not have the records. It was not mentioned by the authors, and VAS score over for a long term was 4.71 for ganglion block and 4.04 for radio frequency ablation. There were 11 failures in the ganglion impart block and 10 in the radio frequency ablation, and there were 3 complications as discussed before in the ganglion impart block, and as such no complications noted in radio frequency ablation. This is the percentage improvement score, that is PIS. That means PIS is inversely related to the VAS. So if the percentage improvement score improves, that means the VAS decreases. So this is the secondary outcome which we discussed already. The ganglion impulse group, there was 31.92% failure rate, that is 11 on 79 patients, and the complication rate was 3/104, that is 2.88% of complications. In the RFA group, there was 14.08% failure, that is 10 on 71 patients had a failure rate, and there were no complications noted. The total failure rate was around 14%, that is 21 on 150 patients, and the complication rate was 3 on 138 patients. No complications like infection or persistent injection site pain were reported. Discussions. Coccydynia commonly occurs in females, overweight and obese population. The most common cause of coccydynia was post-traumatic, that is 62.29%. Going at the pathology, is ganglion impar is the there is a chronic irritation of the coccygeal nerve due to the biochemical alteration of the coccyx due to increased sensitization of the ganglion impar, which is the relay point for coccygeal nociception and somatosensory system achieving. So when we give a block there, we achieve the analgesic effect and decrease the sensitization. The success of this blockade depends on the accurately locating the ganglion. Furthermore, there were 7 different authors and they used different ways of going through the needle placement. So the first one was use of bent needles through the anococcyx ligament while placing the non-dominant hand index finger in the rectum to avoid any breach. So this one. Then secondly, inserting the needle through the sacrococcygeal ligament via sacrococcygeal approach directly into the retroperitoneal space. This is the one, and this is the needle insertion. Then there was a modification done here, and needle inside needle technique to avoid patient discomfort due to multiple needle insertion. Then there was a first intercoccygeal joint, that is this one approach, and stated that this approach carries the advantage of allowing the injectant to be closer to the anatomical location of the ganglion and thus easy to visualize on lateral fluoroscopy compared to the sacrococcygeal joint. The sacrococcygeal joint gets obscured by the cornea of first coccyx in the lateral fluoroscopy. Also, in certain patients, there was a fusion of sacrococcygeal joint fusion, and that was around 52 patients with idiopathic coccydynia compared to the intercoccygeal joint fusion seen in 12% of the cases. To overcome this difficulty, also the first ICJ approach was used. An alternate technique described in case of calcified sacrococcygeal ligament insertion of the needle to needle via short and thick introducer needle. The paramedian approach, in which the insertion of needle below the transverse process of coccyx and redirected it towards the midline, can be used in corkscrew maneuver. So these are the different methods different authors have used throughout the study to perform the block or the radio frequency. Now discussion. The systemic review shows a percentage improvement of 60.28% in short term and 39.85% at 6 months with a mean VAS of 3.11 and 4.71 respectively. This data also includes failures, thus further improvement in VAS and PIs can be expected with those responding to treatment, which is a whooping majority of more than 85%. Discussion further on, there's a separate group of late responders other than responders and non-responders who are easily identified with immediate post-op scope. So non-responders are the patients, late non-responders are the patients who had immediate post-op relief, but later on the relief was not there. Hence, the reason for this could be that these patients could be presence of higher threshold to block or ablation or inadequate placement of needle or probe. Concluding to the study, the ganglion impulse block and the RFA are intermediate treatment options between conservative option of medical treatment and radical option of surgical excision. They are minimally invasive and can eliminate unnecessary surgical burden in majority of patients, unresponsive to conservative medical management. Considering a success rate of more than 85% with either modality and nearly 90% with conservative means, the need for surgical excision is reduced to 1.5% in such patients. The choice of GIB or RFA shall depend on the availability of resource, the skill of treating doctor, and patient's choice. Limitations accepted throughout the study were no comparative randomized trials was available, therefore not included in the review. A detailed review could not be performed on the basis of demographics since some patients didn't report basic demographic parameters. Coccydynia patients with traumatic, idiopathic, and malignant etiology were not assessed separately due to non-availability of separate data. Continuous and pulsed radio frequency were considered the same under the same category. Critical analysis. First is certainly a need for larger randomized comparative study on GIB with steroid and neuromodulation and radio frequencies required for more clear results. The failure of procedure due to anatomical variation hasn't been clearly explained. Thirdly, would be superiority of any of the techniques not known. Hence, the most useful one is clearly not known because there were 7 authors in differently performed techniques, and no mention about the needle size of the radio frequency and longer pain relief beyond 1 year hasn't been discussed. The take-home message is ganglion impulse block and RFA are intermediate, minimally invasive treatment options between conservative option of medical treatment and surgical excision, eliminating unnecessary surgical burden in majority of the patients, unresponsive to conservative medical management with a success rate of more than 85%. Thank you.
Great. Thank you, Dr. Maitri. Now I will just share the slide and introduce Dr. Jeshnu. I'll just put up my slide. So Dr. Jeshnu is MBBS, DA, FIPM, FIAPM, EDPM. So he's assistant professor in charge pain clinic at JNMC Wardha. He's a consultant mitigate pain clinic at Nagpur. He's a visiting consultant at HCG Cancer Care Hospital Nagpur and also visiting faculty Dardia Pain Hospital in Kolkata. He's got 11 publications in national and international journals and 1 chapter in a book. And he's also faculty at various CMEs, webinars and conferences. He's got 2 paper and 3 poster presentations as postgraduate in conferences. So welcome, Dr. Jeshnu. Over to you for conducting the discussion now.
Thank you, sir, for the nice introduction, and congratulations, Maitri. You have presented the paper very well. The house is open for discussion. If somebody wants to ask the question, please go ahead. And the paper has rightly described that there are various methods which everybody are using, but among these most common what we have seen people are using is transcoccygeal approach, or what you can sacrococcygeal ligament, which you have mentioned. And you have mentioned that needles and size they have not mentioned very well. So what I have been doing in my practice is I use a small hypodermic 2.5-inch needle, which comes with your drip set or BT set or whatever. And in that case, if you are giving very good local anesthesia, then the need for even during needle to needle technique might not be raised. So, okay, and if you are going by fluoroscopy, obviously that is what is recommended, and piercing the sacrococcygeal ligament, going gradually under fluoroscopic guidance, and then seeing the contrast rate, which is very well described by Dr. Sidharth in his previous video. That is the best approach. What I find myself, because bending the needle and going through, going beyond the coccyx and then piercing is a little tedious and practically little difficult. By putting your hand in the rectum and all those things. And I would like to share one of my patient who was presenting with this coccydynia and was not ready for radio frequency somehow due to some practical issues. What we did for that case is we first give steroid, ganglion for local anesthetic plus steroid. He had relief for only 20-25 days. He came back, but again he was not ready for RF. Then we again injected steroid with local anesthetic. Yeah, important to say, he was not responding to medical management and physiotherapy. So in second sitting, the duration of effect for this steroid and local anesthetic lasted longer, little longer. It was around 30-35 days. Again, he came back after 35 days. Again, we did the same procedure. As the requirement for steroid is much lesser, we were injecting only 10 mg of steroid in each setting, so that was not the issue for overdosing. And in third setting, he had much longer relief, which was around say 45 or some 50 days, but which was conveyed telephonically. He didn't come back after that. So we expected that the pain still might be there with the patient, but it was well controlled on medication, or NRS might be only 1 or 2 something. The patient was not coming back with after the third repetition. So this might be the, but we need studies for such things also. This is just one incidence which I have seen. Otherwise, obviously we go for radio frequency for longer duration of effect.
So Dr. Jeshnu, how common is this procedure in your practice?
Not so common like rest of the back pain procedures. Coccydynia is not so common, and most of them respond to conservative management, like using a coccydynia pillow and medications and lifestyle modification are doing wonders. Not many patients require interventions.
Great. And what about your experience with any cancer patients wherein you have done this procedure, or any other indication,
Patients who are coming with the CA rectum and a lot of pain, but I would prefer for them, because when a patient is presenting with CA rectum, it is not only very unlikely that it is demarcated to distal 1/3 of the rectum. If that is the case, then well and good, go for the ganglion implant. But in my practice, I haven't encountered with such a demarcation that it is only to the distal 1/3 of the rectum or like that. So preferably in those cases, I go for superior hypogastric.
Okay, great. And do you do any sitting, standing?
I'm sorry, the connection was little lazy. Can you repeat?
So do you do any the sitting and standing X-rays, or have you, any colleagues done manual under GA, manual, you can say modification of the position or manipulation under GA? Have you seen any such patients?
I haven't seen, but once with when I was discussing such cases with my orthopedic colleague, one among them was doing this little bit of manipulation under mild sedation, not under GA or something, under some sedation. But again, he was also not very sure about the outcomes for those things. I personally haven't done that thing.
Great, great. So thank you for these insights. Dr. Maitri, if you would like to ask anything, or Dr. Jeshnu, if you would like to ask anything, Dr. Maitri, you can do it now.
I wanted to ask that there was this term late non-responders, that they responded immediately after the treatment, but on the longer run, they did not respond. So how do we go about these patients, even after an RFA or the block? So, sir, one way was shown that you give a repeat injection or so, but what could possibly be done that this doesn't happen, or what is the way to go about it, maybe, or the reasoning behind that?
See, when you are, this is like one of the drawback, or what we can say, limitation of this study. When you are defining something, you need, if you are coining some term, you need to define what do you mean by that? What is meant by late responder? They haven't defined it, right? So
So
late
they've briefly mentioned that there are these patients who responded immediately after the treatment post-op. That could be because local or what or something, and later on they stopped responding and they started having the pain which was similar to the VAS score at the baseline.
Yeah. See, what happens when you're injecting local plus steroid, right? So local will have immediate effect. And once you break the pain cycle, along with that, you might be giving some NSAIDs and antidepressant. So that might be taking care of pain relief. And usually in such cases, steroids, we are not giving here for, you need to understand, steroids, we are not giving here for this analgesic effect or anti-inflammatory effect. Steroids here are being used as a membrane stabilizing effect. So to have that membrane stabilizing effect, it takes some time, might be 24 to 72 hours. So here in this particular paper, what late responders means, they haven't defined whether it is 2 days, 3 days, like 24 to 72 hours. So this is very common. This not only with the Coccydynia patients, with any kind of patient where you are giving going for local anesthetic plus steroid, this may happen, that effect may come only after 24 to 72 hours. And for radio frequency, obviously we all know here, I preferably go for conventional radio frequency for this patient. And conventional radio frequency effect usually appears after about 21 to 28 days. And that may be the cause that they are finding it late responders. And along with the conventional radio frequency, again you inject some steroid and local anesthetic to avoid the differentiation pain and whatever the going on, and pain during the thermal ablation. So sometimes that steroid is taking care of the pain for 15-20 days, and then radio frequency effect comes. So this can happen. Yeah, there is one question. What Dr. Samriddhi Nanda, what physiotherapy do you advise for the management? Are there any exercises that might help? Yeah, for physiotherapy, I preferably send the patients to physiotherapist and do not do everything myself. They go for some neurostimulation, something like TENS or something like that. And for exercises, it is basically this pelvic floor strengthening, pelvic floor muscle strengthening exercises, physiotherapist advice. Then another question by Monica.
So I'll add something here. For the coccyx is a very important structure. It may look that it is no attachment, but if you see my talk, I have taken the muscular attachment, which, it's laden with all the attachments. And if it is, the tip is bent even slightly, so there's bound to be a muscular imbalance. So if you see those exercises which bring the bone to the neutral position, or which kind of improve the pain of the patients, they are kind of arbitrary. It is not sure which of them will work. So even your physical therapist will be as confused as you are. So however, it is still better to get them on board immediately and get a good experienced one who has some experience of at least doing some pelvic exercises or treating some such patients, because then it will, or maybe get those who are working with post pregnancy patients a lot. So then because the exercises are similar, if you will see the literature, the exercises are similar, so that can help you out. Then if you are asking to prescribe yourself, I will desist from that, because it can have adverse effect as well. So the patient's pain may aggravate. So try to get an expert, as Dr. Jeshnu has mentioned.
Yeah, completely agree with Siddharth sir. Don't do everything yourself. Try to include the experts of those specialties into your team. Physiotherapists, good physiotherapists help a lot in your pain practice. Yeah, another question by Dr. Monica Chogle. What are your settings for PRF or RF and how long? Yeah, I personally go for conventional RF and it goes for 80 degree for 90 seconds, 2 or 3 cycles. So for PRF, I'm not doing it, so I'm not the good person to comment on it.
So PRF, actually there is a negative recommendation by one good study by one of the popular authors in the US, and I have quoted that in my talk. And second, unfortunately or fortunately, they have come up with another positive recommendation study. So PRF, in my opinion, is always dicey. Some people get some great results, they are swear by it, and some people will get very dicey or negative results with it. So what I'll tell you the settings. So 42 degree is the temperature, is the usual one which we use for PRF, and what one of the authors, they have used 10 minutes as the time, and they have done multiple PRF lesions at multiple points. The key here is that prevention of neurodestruction is there with PRF. So then they can do much higher number of lesions, and one of the authors have gone to do as much as probably four lesions on one side, and they have lesioned the whole of it, whole of the course of the nerves also. So it's quite adventurous, and I will probably not like to do PRF as well, as Dr. Jeshnu has mentioned. And for RF, it's the same setting which I also have used in the past.
Yeah, as the question for RF has raised, I just wanted to discuss one more case. In one of my the case was planned for conventional, and I was trying to go through sacrococcygeal ligament. And unfortunately, it was so much calcified that I wasn't able to pass through the sacrococcygeal ligament. So in that case, what I did, I bent the conventional probe little more than the routine one, and then I went through the paramedial approach. And instead of one probe, I did it at inserted two probes from both the paramedial approach, and then went for bipolar one. And I tell you, it gave excellent result. But it is not recommended. It is not
No, it is done by other physicians also. Although bipolar is, I don't know how much it will be good, but or maybe risky, but of course you will get a bigger lesion if your tips are within that range. And second thing is, the bent needle technique is already mentioned. So you did nothing wrong. I think it was very wise of you to do that. In my practice, what I do is I never do the sacrococcygeal. I always do C1-2. So there was not even a single case where I have faced any issues going through the disc because of this reason. Probably it is less chances of this being calcified. Only thing is you need a very good C-arm to accurately see and count the segments and account for the anatomy and all that. My take on this is just count from the S1 you count downwards, and you go on if you can find the fifth space, it's okay, very good, go from that. If you can't find, go for the sixth space, and I think that should be it. This is what I will suggest here.
Right. Another question from Dr. Samriddhi Nanda. When do you do a caudal epidural for the condition?
So I think this is done when there is a referred pain. So coccydynia is a condition where it can be either a direct pain, which is arising from the posterior structures, which is the time when all these, whatever we are discussing techniques will work. And second is, you very well know that the coccygeal nerves, they are, they are coming right from the spinal nerves, they're spinal nerves. So you can find that, and during their course, throughout their course, they can be affected anywhere, and plus the pain can be referred from the higher structures also. So in those cases, the caudal epidural is likely to work more. So these cases will be having a very non-specific pain, which will probably not be affected with local, movements or by sitting. So these patients will say, I don't have any pain on sitting. I am like, it's okay, a little bit it pains. They will not give a very great history of tenderness or any local pathology. They'll have no history of fall. They will have, so these are very select subset of patients. And if you see the papers which I have quoted, one of them mentions this in detail. So the difference between referred pain and the pain which is arising from. So your job as a pain physician is to more of locate, find out these different causes and then kind of, use your techniques to get rid of them. So the initial exercise and physio and medications, the pain which is getting relieved is one of the types of pain which is the cause of it. And after that, whatever is remaining, you have a higher chance of success with your procedures. Please let me tell you that there is anterior innervation of this region also, which we have not even touched. So just see the talk and you will understand that anterior innervation, if that pain comes, it cannot be tackled posteriorly. So this is very important to understand. Okay, so I hope we have covered some of the things which were asked. Okay, thank you, Dr. Smriti and Dr. Monica and Dr. I think both of you have asked only the questions. Okay, good. Thank you, both of you. You have asked great questions for the insights. Dr. Maitri, anything we'd like to ask? Otherwise, we'll just go on and end the session.
Covered all.
Okay, so guys, first of all, special thanks to Dr. Jeshnu and Dr. Maitri for the excellent presentation and moderation. Thank you both for coming. And I think it was a great session. Really enjoyed talking with both of you. So now moving on to the next steps. The secret of getting things done is to act. Join our mailing list, guys. Just click the link which I posted in the chat for WhatsApp group, and suggestion comments are all welcome. Just mail them to mumbaiPainSchool@gmail.com and just join us for our hands-on MIPSIs, our hands-on workshop, which is the only one of its kind cadaveric workshop with full 3 days of cadaver. We don't have any theory part here. So we are covering all the procedures. Last 2 times we have been able to cover all the procedures. First time a couple of them were left, but second time that feedback from delegates is absolutely awesome. And there was not even one guy who didn't get a good hands-on and all. So join us for this hands-on MIPSIs, and it's happening on 25th to 27th March. The early registrations are closed now. So we are in the standard slabs, and this one is also going to close very soon because the days are approaching fast. So see you around. Thank you very much, and keep learning. Bye-bye.